Good morning or afternoon once again, everybody, or even evening, depending on where you are in the world. Thank you very much for joining this webinar today on healthcare for people, not silos for diseases. And we're going to be exploring relevant solutions to shape a future of integrated care for NCDs. And just as a little bit of background, this webinar builds on a report that was commissioned by Lily and produced with the NCD Alliance, and was really, it came out of recognition of the fact that there is now really strong global policy in place for non-communicable diseases. And we realized there was a need to look more at what practical barriers exist to implementing comprehensive care programs for NCD prevention and control, and what some of the more practical solutions were to this. I'd just like to say that there is an opportunity to type questions in the chat box that you can see on your screens, and we'll address any questions that come in during the question and answer breaks throughout today's webinar. Can I have the next slide, please? And so just to run through the agenda for the webinar today, we're going to be looking firstly at the challenges and solutions. Why integrated care for NCDs? What does integration have to offer? In particular, it's a fairly nebulous concept, so we'll be looking at the key areas of focus for action to try and make the concept of integration much more comprehensible for everybody. Well, I'm sure we've got many experts on the line. And to help with this, we're going to have 3 presentations on case studies from the field. These will be from PATH on integrating hypertension screening at primary care level in Vietnam, from HealthRise for community-based NCD interventions in India, Brazil, and South Africa, and from AMPATH, who are implementing a project on integrating cancer care with existing HIV service delivery systems, which are already much stronger in Kenya. So some really fantastic geographical representation in here, and looking forward to learning more. And finally, we'll be hearing about the opportunities for action and how we can accelerate integrated care for NCDs in the context of universal health coverage, which everybody knows is especially topical at the moment. If we turn to the next slide, just to set out the top line objectives for this webinar, we're going to be looking at the challenges posed by NCDs to health systems, what integration can offer in terms of solutions to overcome these challenges, how greater integration for NCDs can result in improved health systems and outcomes for people, and what the major opportunities are to accelerate integration for NCDs in the broader context of UHC. And we've got a fantastic panel today with Katie Dane from the NCD Alliance, who's going to be giving us the initial overview, an introduction to set the scene of the rest of the presentation. And then, of course, Evan Lee, who's the advisor of Lilly Global Health with Eli Lilly and Company, Dr. Kim Green from PATH, Jessica Daly from Medtronic Foundation, Dr. Chite Asirwa from AMPATH in Kenya, and then finally a few words from me. So without any further ado, I'll pass over to Katie Dane to talk us through challenges and solutions and why integrated care is important for NCDs.
Thanks very much, Jess, and good morning, good afternoon, everybody. Thanks for joining this webinar. So if you go to the next slide, I'll just be providing a brief overview to kind of set the scene of why we embarked on this report, Shaping Health Systems for the Future. I think everyone on this webinar will be aware that we were producing this report in an important year for global health. It was the 70th year anniversary of the World Health Organization, and it was also the 40-year anniversary of the Alma Ata Declaration on Primary Healthcare. And it was also just, a couple of years in advance of the UHC UN high-level meeting that Jess will be talking about at the end. And what is obviously very well recognised with that landscape is the fact that the actual picture of global health has really changed very dramatically. There's been really significant improvements in reducing the burden from infectious diseases and maternal and child deaths. And against that backdrop, we've seen a real rise in the burden of non-communicable diseases in every region of the world. And what this graph shows is this really important global epidemiological transition with NCDs now the leading cause of morbidity and mortality around the world, causing 71% of all deaths, which is the equivalent of 41 million people dying every year. But it's obviously completely changed. It's obviously completely busted that myth about NCDs being very much a high-income country issue. You can see at the bottom that yes, NCDs continue to be a high-income country issue, but actually it's really a low and middle-income country issue that's most worrying, and it's now affecting every single region of the world. And even in sub-Saharan Africa, we're beginning to see a real increase and expected to see a rapid increase in NCDs over the next decade or so. Next slide, please. And it is really this story of NCDs in low and middle income countries that the report really focuses on. We're seeing a real increase in NCDs in low and middle income countries, and what this slide shows is that between 1990 and 2010, there's an increase from 18 million deaths from NCDs to 26 million. And until 2030, what is expected is that NCD deaths are expected to rise by over 50% in that time frame. And in terms of what the drivers are of this very changed picture of health in low and middle income countries, are those major drivers of globalization, rapid urbanization, and demographic changes. So now, as I've said before, NCDs are very much a kind of priority in low and middle income countries, impacting upon the most vulnerable populations most often. And it's really this that is the kind of focus of the report. Next slide, please. The other concerning thing from an NCD perspective in low and middle income countries is that it's a markedly different picture of what the NCD burden looks like compared to high income countries. And what we know is that NCDs are often occurring much younger, in the prime of people's lives, and actually roughly approximately 10 years younger than in high income countries. And so this slide shows the probability of dying from diabetes, cancer, heart disease, and lung disease between the age of 30 to 70. And as you can see, the red, where it's the highest probability of dying between those young ages, but before the age of 70, are very much low middle income countries, many African countries, as well as Southeast Asia. And we also know that in terms of when people aren't dying, the actual outcomes are a lot worse, which is really contributing to this vicious cycle of poverty and deprivation. Also caused by the fact that much of the care for NCDs in low and middle income countries is still out of pocket, so causing catastrophic expenditure for people, and pushing people into cycles of poverty. Next slide, please. So against that backdrop of a very changed epidemiological transition is the fact of where health systems sit in how they're tackling NCDs. And we all know, I think many on this webinar know, that NCDs do pose quite a unique challenge to health systems in low and middle income countries. Firstly, because of the very chronic nature of these diseases, and the fact that health systems have historically been designed to provide care much more for acute health conditions in which people are assumed to be healthy most of the time, while occasionally and temporarily suffering from illness. And they're less oriented to kind of chronic conditions where people are going to be needing constant care over their whole life course. And in that way, it obviously requires a very, very different health system. Secondly, it's a different story because most people are actually impacted upon by multiple morbidity. And in a recent report by the George Institute, actually, they were kind of stating that multimorbidity is increasingly becoming the norm rather than the exception. And that obviously cuts across the different NCDs, the different kind of interconnections between hypertension, diabetes, etc., as well as the connections between the comorbidity of infectious diseases and non-communicable diseases. Obviously, HIV/AIDS now being a chronic disease and people living to a much longer life due to progression in treatment. But now many HIV patients are now developing diabetes later in life. So it's that kind of challenge of multimorbidity that this report is also trying to tackle. I've already mentioned that NCD risk is a real life course challenge from very much as early as in the womb to old age, and that poses unique challenges to how health systems are responding. As well as we all know that NCDs, wind up in health systems, but they're actually really they're rooted in actions well beyond the health system, and they require action, particularly with social determinants, including poverty and education and gender equality. So again, this kind of poses very, very different challenges of how public health systems are responding to non-communicable diseases. And we see time and time again in terms of people living with NCDs and the challenges that they face on the ground. And these are just a few quotes from people that we have spoken to over the years in terms of really highlighting the challenges of distance to health centres and the need for transport and the amount of time that takes to get to these health centres, as well as really highlighting the kind of cost and the fact that impacts upon the whole family's family economy, as well as obviously the huge delays that can happen and the impact that has in terms of outcomes for people with NCDs. So very, very real challenges that people are facing on the ground. Next slide, please. So the way that the report has looked at it is that we have addressed the challenges posed by NCDs to health systems across 3 levels: across community level, across the health centre level, as well as the more systemic level. And we've done this because we recognise that all 3 are very much kind of interlinked, but each pose quite different kind of challenges. And just to go through a few of these briefly now, in terms of some of the challenges posed at the community level, it's things like limited health literacy and awareness, as well as kind of a lack of guidance aligned to local context and infrastructure. So particularly at the primary healthcare level we're talking about here. Also the lack of kind of community-based interventions, which is a challenge there, as well as kind of obviously I've mentioned the kind of social determinants and the socioeconomic inequalities and high out-of-pocket payments that we're seeing at the community level. At the health centre level, we see challenges around a lack of standardised clinical protocols for NCD management, as well as quite complex and unclear referral systems, and many people are getting lost in the system. At the health centre level, there's a huge challenge around overloaded workforce and lack of specific interdisciplinary health workforce for NCDs, which is so important. And as well, obviously, the major challenge at the health system level being limited availability of medicines, technologies, and weak supply chains as well. At the more systemic level, some of the challenges that we have highlighted in the report is weak monitoring and evaluation, as well as, again, the workforce capacity to provide specific care needed for NCDs at this level. As well as limited coverage for NCD services. So these are some of the challenges that we have highlighted through those 3 different levels. If we go to the next slide. Next slide, please. So in terms of really leveraging the potential of integration for NCDs, what our report is really highlighting is the need to address all levels in parallel, both at the system level, the health centre level, as well as the community level. And what we're proposing in terms of what that will actually have an outcome on is using a definition of WHO in terms of integration is the organisation and management of health services, so that people really get the care they need when they need it in ways that are user-friendly, achieve the desired results, and really provide value for money. And what this will actually achieve is that essentially we will be putting communities and patients at its heart, which is so important. So often we're not seeing health systems really oriented and responding to patient needs. For NCDs, it really means a focus on the primary healthcare level. It has to be the centre of what we're focusing on in terms of health system strengthening, which is obviously a big theme for the Universal Health Coverage High Level meeting next year. and it needs to be adapted to national context, which is an obvious one. But just to really highlight that again, that obviously health systems across different countries are all completely different, but we can really learn from what's worked in different places and really try and translate and tailor it to those national contexts that we're working in. Next slide, please. So I think that's my side of the presentation in terms of providing the overview. Obviously, if there are any questions, happy to answer.
I've got one question, Katie. So just in relation to some of what you covered on the last slide, in terms of, what are the next steps for how we ensure the success of integration and leverage its potential? You mentioned the UHC high-level meeting and the need to focus on primary healthcare. How in this transition from global policy to national level implementation do you think that civil society has a role to play? And I'm asking civil society specifically, given that we'll be hearing from other sectors later on the call.
Thanks, Jess. Good question. I think civil society has a huge role to play in all of this, because often it's civil society organisations that are providing the essential services, life-saving services on the ground for people with diabetes, cancer, cardiovascular disease, lung health, etc. So as service providers, we play an important role. We also play an important role from more of an advocacy perspective in terms of really building the demand for effective health services for people with NCDs. So making sure that it really reflects the needs of people. Also, we play a role. I think one of the big themes, obviously, of this report is really around integration, and both from the global level to the country level, we can play an important role in actually building synergies with other areas of global health, so that we're singing from the same song sheet, as we like to say. So with the TB community, with the HIV/AIDS community, with women and children's health community, etc., so that we actually, as civil society, are walking the talk in terms of integration. So I think those are a few areas of how civil society has a key role.
Thank you very much indeed, Katie. We're going to hear now from Dr. Evan Lee, who's the advisor of Lilly Global Health at Eli Lilly and Company. And I just wanted to really encourage people, if you do have questions, please do type them in the Q&A box, because we'd be really glad to have an interactive discussion. Thank you. Over to you, Evan.
Thank you. Hello, all of you. I see that there's 59 people on today's webinar, which is wonderful. I want to start off by thanking and acknowledging the hard work of the NCD Alliance team to make this webinar possible. Also acknowledge my former colleague, Amy Israel, who was really the driving force behind this and worked closely with the NCD Alliance team to put the report together, which is a great resource. I also want to thank my fellow panelists, some of who were also involved in the production of this guide. With that, turning to the next slide. This is the report we're referring to, which is available on the NCD Alliance website. As a former primary care physician and a life long ago before the journey that took me to Lilly, I was a primary care doctor, so this subject is also close to my heart. It's challenging. The word integrated care is easy. The way path forward is not easy. You saw some of the challenges that Katie highlighted on the previous slide. So this report includes case studies, some of which you'll hear about in more detail live from the folks involved, but they're also described in this report, which is truly a multi-sectorial collaborative effort. Next slide. So just looking forward to the next section, and also to provide another framing for implementing integrated care. You'll hear different examples, and there's different models. You saw a description of some of the challenges at the health center level earlier. Another way of looking at this, because there really is no one magic approach to this, is looking at this along a cascade of care. One of the case studies you hear about talks about how that worked a little bit more in practice, I believe, but ranging from prevention to early screening, early detection, screening, treatment initiation, and then actually management of the disease, because many chronic diseases, thinking specifically of cardiovascular disease, diabetes, and hypertension, those are the ones I know better. Actually, treatment modalities shift during the course of the illness, which is part of the chronicity and the challenges. Also in this, I mean, you're aware, many of you are aware that the communicable diseases haven't gone away. And this actually provides a sort of framework that's been used in one of the case studies with AMPATH, where NCD control was integrated into existing health programs. So that's one model. You hear a little bit about that more shortly, I hope. The second model is, again, looking at different levels of the health system. And you'll hear from Kim Green from PATH on that. And the third model is also looking at integrations that can address common risk factors together for non-communicable diseases. So again, a lot of different ways. And just turning to the next slide, some of the overriding factors, no matter which model we use, is the need for an integrated and enabling environment, which has to occur at the political level to mobilize the resources. At the same time, be realistic and realistic in terms of implementation, based on where the health system is today. You all come from very different countries, very different health systems, but that's always going to have to be the foundation from which this work starts. And to incorporate this not on just a technical level, but to think about human resources and financing. Similarly, in terms of training, the trainings, whether it's a medical school, a nursing school, or community health worker training courses, this has to be, integration has to be embedded across all different types of health, all different levels of healthcare workers, different disciplines, and very much the case, as we saw, I think, with communicable diseases like TB and HIV, you know, the importance of a team culture where different health workers have different disciplines, but all can work and need to work together to support a person affected by an NCD in their journey. Fundamental to all of this is the need to capture and share data. This comes up, you know, not only in terms of monitoring the evaluation and then to support learning, but also simply for better patient management and coordination among the different team members. And that leads naturally to the need for ensuring effective governance and a collaborative and trusting environment across different stakeholders, and thinking carefully about how to allocate adequate resources at all levels of the health system. In other words, it's not just about commodities. That's essential. It's not just about infrastructure. It's not just about training, but each of the allocation of a given set of resources has to be thought through carefully to be able to accomplish the goal of integrated care. So I think the best thing is to kind of move quickly into some of the case studies, which can make this much more tangible for you. But we do have just a few minutes, a couple minutes, for if there's any questions on the Q&A.
Thank you, Evan, very much. There are no questions in the Q&A box, but again, one from me. Just a comment, first of all, that it was such an honor to produce that report with a company with as much expertise and strong global partners on the ground as Lily does. But just to ask, the three models that we focused on in the report, you know, that there was a question on where we should be focusing when we were looking at that. And I just wondered, given all of your expertise in the area, if there are other definitions of integration or different integration models that you think are worth mentioning, even though they weren't a strong focus in the report, or if you think it covers everything that's relevant.
I mean, I think just coming back to the principles I enunciated, it is a huge area. When you think of even, you know, just as a former primary care doc and thinking of the folks who would come into my office, whether it was, you know, an injury, an acute injury, to adjusting somebody's blood pressure, to an acute infection, like a chest infection, it is very hard to get your hands around it easily. I think what you'll see in the case studies is that proceeding carefully, being guided by data, understanding the state of the healthcare system that you're working with, which includes also the level of the healthcare system that you're going to start with, as well as sort of the, the priorities of the ministries of health. Those are also considerations. I know that runs the risk of repeating what I said, but there is no one sort of magic approach. So hopefully by hearing a little bit more about the case studies and then reading the reports, you can get some ideas. I do see one common theme, having just reviewed the report the other day, is I think a common theme across all of this is not trying to do everything at once, but looking at building integrated care maybe off of one strong vertical disease program. In the case, you'll hear about HIV, for example, or looking at one NCD to focus on for integrated care and prioritizing that as opposed to trying to do all NCDs. So I think focus is also another way to look at that, and prioritizing how you sort of build out an integrated care system, and then having the approach in place to monitor, evaluate, learn.
Thank you, Evan. And we've actually just had a few more questions come in the chat box. One from Gordon on what's the role of technology in the integration, in the context of NCDs. Are you happy to take that one, or should we wait till a bit later in the presentation?
Well, I mean, I'm happy to do that. I'm going to assume that question is about digital technology. Well, I'm going to address that first. I mean, I think digital technology has great potential, but again, it can do a lot of different things. And thinking about what you're trying to achieve with a digital platform, whether it's use of a mobile phone, or let's say an artificial intelligence that's starting to appear on helping support a healthcare worker to have greater capacity to manage a wider range of diseases, or simply managing patient data. I think that's also going to be important. I think there's great potential there. I hear a lot the digital health term, digital health thrown around a lot. I think in any given setting, you've got to be very careful about how that's implemented. Again, just in this format, the other aspect of technology, I think we're seeing progress on diagnostics and diagnostic capabilities, some even new technologies maybe for delivery of medicines. I think that's also important too, just on the medical technologist side to look at and find ways to integrate. I mean, one example is a point of care A1C for managing diabetes. But before rushing out and buying that, I mean, again, that would sort of have to be in the context of an overall strategy and plan for integrated care, and deciding whether or not diabetes was the first priority, or cardiovascular disease, or doing both together. So it does require some fairly systematic thinking. Let me know if I can take another question.
Thanks, Evan. There are actually 3 more questions, and we're a little tight on time, so I'm going to ask all 3 of them, but if you can be as concise as possible, because I'm sure there's lots to say about them. So there's one also building on the similar theme of technology, on whether or not you see an application for artificial intelligence in improving integrated care or quality of care.
Yes, I think I answered that. I think it just will depend on the setting, and is never a substitute for human contact, but can certainly help.
Thanks, Evan, and sorry. Okay. Then I'm not actually sure we're going to be able to address all of the ones that have just come in at the very latest. So to pose 2 out of the 3 that are remaining, whether there is any pilot study for integrated care for NCDs like PROTEST that have informed the TB and HIV collaborative activities, including the models of integration and monitoring and evaluation. I personally don't know what PROTEST is.
I'm sorry, I don't either. So if there's a format for taking questions offline that we can look into, we'd have to take that offline. Thanks.
Sure. Janine, we can get back to both of your questions offline in that case. Sorry for not being able to take them all on the call.
Thank you for asking. I chose an engaged audience.
And I think, yeah, just given time, I think we will push ahead now, and if we've got more time at the end, we can take the others too. So thank you everybody for putting in those questions, and hopefully we'll be able to come back to them. So for now, if we move on to the case studies, the lessons from the field, the first presenter that we're going to be hearing from is Kim Green, who is Global Director for HIV and Tuberculosis at PATH. Kim, over to you. Thank you very much.
Thank you so much, and thank you to the NCD Alliance and to Lily for your thought leadership around integration. It's really important, and we were honored to be a part of the report. So I'll be presenting on from the conventional to the creative, expanding access to blood pressure screening and hypertension care in Vietnam. Next slide, please. So as Katie talked about in her overview slides, Vietnam is very similar to other lower and middle income countries where chronic disease management for NCDs is relatively nascent. There are, however, strong strategies and policies that are in place related to NCDs, but the real challenge is around the systems to enable a continuum of care. And like in other locations, in Vietnam, there's a strong history of working in HIV and in TB. And these programs are providing learning and opportunities around case management, which Evan touched on, self-care approaches, adherence tools, and different ways of offering integrated training to providers. So in Vietnam, 25% of adults have hypertension, and around a third of those cases are untreated. And the prevalence is twice as high in urban areas than in rural areas. Next slide, please. So to address the challenge of NCD service delivery in Vietnam, as Evan mentioned, we selected hypertension, given the high burden in Vietnam, to really look at how hypertension services could be offered through the community level. And so Novartis Foundation and PATH worked together to co-create the Communities for Healthy Hearts initiative. The aim of this initiative is to improve blood pressure control among adults in Vietnam by increasing access to and use of high-quality hypertension services that are sustainable and scalable. And the project focuses on reaching people who are aged 40 and above and works in 4 districts in Ho Chi Minh City. The chosen districts are those that are lower income. And the project will go up until the end of 2019. So the partners, in addition to PATH, are the Ho Chi Minh City Provincial Health Department and Preventative Medicine Center. They're at the center of implementation. The Hanoi School of Public Health, who are conducting an independent evaluation. Novartis Foundation, who of course are the primary donor and have been a key collaborator. And then 2 social enterprises who were selected through a competitive process of an innovation fund, both G-Link and Galant. Next slide, please. So Communities for Healthy Hearts is founded on 5 key objectives. The first 4 really focus on the patient journey across the care continuum. So the first objective has everything to do with increasing hypertension awareness and awareness around cardiovascular disease risk factors in the community. The second objective focuses on increasing screening for hypertension and referrals in the community. The third focuses on increasing the quality and access to treatment both in the public and the private sector. The fourth piece, which we are finding to be the most challenging, but equally the most important, is in the follow-up. So community-based follow-up and case management focused around treatment adherence and lifestyle changes. And the 5th objective focuses on generating evidence for decision-making at the local level and at the national level. Next slide, please. So the project is very much about a partnership between clients and families, the community, and the healthcare system. So there are 53 public and private health facilities that are part of the network that offer clinical hypertension services. And they coordinate then with the primary care facilities, the community health stations, of which there are 16 that we work with. And they're offering primary case management for hypertension in Vietnam. And one of the reasons why we're focused on the primary care level is only 20% of commune health stations are equipped to manage hypertension. So this has been an important focus of our work. And then these community health stations manage 132 community volunteers, and they're trained and equipped to focus on raising awareness, providing screening and referral services, and community-based case management. And then in that effort to increase access to blood pressure measurement, there are 528 checkpoints. These are operated by a combination of non-healthcare workers and also pharmacists. And they offer blood pressure measurement, information about hypertension, risk factors, and referrals. And then, of course, working together with those that are at risk and those that are diagnosed with hypertension and their families to build self-care skills, support adherence to treatment, and make lifestyle changes. Next slide, please. So in order to support CH2's work, electronic patient registry was developed called the Hypertension Tracker. And here, essential health information is collected on clients through the commune health stations and the community volunteers. And then, in addition, there's an automated SMS system which provides friendly reminders around treatment adherence, which are sent once a week for those that opt in. Next slide, please. So the next slide features one of the many volunteers in the community that run checkpoints. This is Mr. He, and he's a retired healthcare worker. He's very passionate about his community. He's well networked and well respected. And he's been able to screen a large number of individuals and then support those that have high BP measures into diagnosis. Next slide, please. The next slide features photos that relates to the diverse sites where blood pressure screening is being offered, or measurement is being offered. So these are in a number of small businesses where there's a lot of footfall, and we're doing this in collaboration with the two social enterprises I mentioned at the beginning. And next slide, please. These two social enterprises are really interesting, and they're very much also about building off the learning from HIV. They developed as community-based organizations and became social enterprises to self-finance in the response to HIV. And in their experience around chronic disease management, were very interested in integrating hypertension services into their work. And so by doing so, they're out in the community building off their current relationships and also run community clinics. And have then been able also to integrate hypertension services for those living with HIV. Next slide, please. So the next slide focuses on an interesting partnership with Pharmacity. As you recall, I mentioned some of the checkpoints are those that are offering blood pressure measurement are pharmacists. And so we've recently partnered with Pharmacity. It's a chain pharmacy across Ho Chi Minh City with 150 pharmacies, but soon we'll have 200 operating. They focus on reaching clients in low and lower middle income areas of the city. And our partnership has involved us offering the training and tools to guide referrals, where they buy the BP cuffs, they're paying for the training and providing the ongoing support to the pharmacist to offer routine screening and referrals. And this partnership is continuing where we'll train all of the pharmacists. And Pharmacity is very committed to continuing to offer this service in the future. Next slide, please. So here is the hypertension care cascade over time from the Life of Project. So in the community, there's been nearly 145,000 individuals whose blood pressure has been measured. Among those, nearly 34% had high values, elevated values. Those included individuals who had previously not been diagnosed from hypertension, and those that had, but perhaps had lapsed with treatment and follow-up. So of those, nearly 66% were then went back into care. They were either diagnosed for the first time or re-enrolled in care, and 81%, or nearly 26,000 of those diagnosed with hypertension are on treatment. Next slide, please. And so then in looking at challenges and solutions, Katie illustrated a number of challenges that are at different levels, and we've experienced many of those. But one that I would like to highlight that is an ongoing challenge is really supporting client adherence and retention. And to address that, we're exploring different models or approaches for case management, both physical and virtual, including more intensive follow-up by community case managers for those that have dropped out of care and or have poor adherence, and also trying to enhance utilization of the SMS service. So for lessons learned, for CH2, we've really seen that this non-traditional approach at the community level has substantially increased access to blood pressure measurement among a poor urban population. We've also seen that non-healthcare workers are highly capable of offering hypertension screening, referral, and case management services. And based on the learnings from CH2, the Ministry of Health is exploring ways in which it can replicate some of the key approaches at the primary care level. And that's all. Thank you so much.
Thank you very, very much, Kim. And there's a question that's come in from Melissa Young asking whether the community health workers and case managers were compensated, and if not, were they incentivized?
Yeah, so for the commune health staff, no, they receive the government salary. So the support with them is around training. For the case managers, the community volunteers, they receive, yes, a very small incentive around supporting transport and time and effort for their work.
Thank you. And you talked us through the hypertension cascade a little, and there was a question from Anne Wales just asking if there's a bit more that you can share on the results of blood pressure reduction.
Yes, so soon. We have the independent evaluation, which is underway. We have analysis that we're doing of the data from the Hypertension Tracker. And so in the next couple of months, we'll be able to share the results related to control.
Thank you very much. Two more questions and then we'll move to the next case study. So one from Gordon Igbodo asking if a patient has a complicated case, for example, hypertension and diabetes, what would the pharmacist be expected to do in that situation?
Yeah, so the pharmacists are trained. They're only trained to measure blood pressure. But if the client had a previous diagnosis of diabetes, regardless of the situation, they would be referring them into one of the district hospitals if it's a complex case. So if it's a simple, straightforward case, they might be referring them to the commune health station.
Thank you. And then from Kenya Ramos, were the referral protocols already in place or were they created for the study?
There's the healthcare system referral protocols that are in place, but we built them out because we were working together with non-traditional actors in the community. So work together with the Provincial Health Department and Preventative Medicine Center to then define what is the role of the checkpoint providers and the volunteers and how they refer. And this is an important piece, and we're working with Ministry of Health to look at developing policy and guidelines around the role of non-health actors in the management of hypertension.
Thank you. And the questions are still rolling in, but again, I'm conscious of time, and it would be great to come back if we end up with more time later in the presentation. But for now, thank you ever so much, Kim. And we will move on to the presentation from Jess Daly from the Medtronic Foundation. And I'm really sorry to people whose questions haven't been answered. We'll follow up on email as much as we can.
Thanks, Jess. Can you hear me okay?
Yeah, hear you loud and clear.
Great. Wonderful. Thank you. Hi, everyone. Well, I really appreciate the opportunity to be on this webinar and share with you today. And also want to thank NCD Alliance and Eli Lilly in particular for inviting us to be part of the report and also to follow on with the webinar. I wanted to acknowledge that in the report itself, we were focused on an element of a program, and we thought for today's example, it would be helpful to sort of contextualize this in the broader global program, so that perhaps the case study in the report allows you to provide greater depth from that broader context. But we have been at Medtronic Foundation and together with our partners working in chronic care and through really integrated models for the last 5 years in a program called HealthRise. And if you go to the next slide, the point of that program was to contribute to the 25% reduction in premature mortality associated with non-communicable diseases, which of course was WHO goal 25 by 25. And now sort of we've continued to align that overarching contribution that we're looking to make to the Sustainable Development Goal 3.4, which is a 30% reduction in premature mortality by 2030, 33%. And so we had a similar to the program that Pat just presented, an objective of increasing detection and improved control of hypertension and diabetes in particular. And the approaches that we took were to empower patients, ensuring that they had the ability to really achieve self-care and were activated in their own care, to strengthen frontline health workers. And so that looks different in different places, but particularly community health workers, and advancing policy and advocacy to sustain gains and to improve long-term health status for the populations that we serve. You see here on this map that we were in essentially 2 districts or sub-state levels in 4 different countries. So in India, South Africa, Brazil, and also the US. For today's presentation, I'm focusing a little bit more on Brazil, South Africa, and India, since the focus is low and middle income countries. But notably, I think a lot of the lessons that we've learned are also applicable in the United States. And we've tried to, across these geographies, create cultures of sharing in a network where we can have sort of a boundaryless approach. And I think there have been a lot of important lessons that have been transferred across each of these 4 geographies. I will say at the outset that this is a partnership model. It takes a number of actors to be successful here. So we have local nonprofit organizations implementing programs in each of these locations. And then we've also had management partners, Apt Associates as our lead partner at a global level, kind of helping to orchestrate the cross-country technical assistance and management. And the Institute for Health Metrics and Evaluation, IHME, is our monitoring and evaluation partner. So next slide. This gives you a little bit of a sense of the framework for the approach to the program. And one thing is sort of similar to PATH in the previous presentation. We are now at the end of almost a 5-year implementation window, and we are in the process of collecting and analyzing all of our data, but also doing some end-line evaluation. And so actually we've kind of agreed with our partners that for the moment we're going to try to consolidate and get to the best level of most accurate numbers that we can. And in a way, I think if this webinar had been positioned in a few months, we would have a lot more sort of rich quantitative information to share, because we are in this sort of critical evaluation stage. But we will, and we have a commitment to making sure that the lessons and evidence generated from this program are shared. So we look forward to doing that. But again, just to give you a framework for how the program was developed, we spent a lot of time ensuring that we understood what the needs and gaps were in the geographies in which we were looking to implement. So we did baseline analyses and needs assessments in each of the geographies that we showed you. We came up with sub-state level estimates for hypertension and diabetes prevalence. We've published those in the case of South Africa and the US. And we looked really through sort of qualitative investigations, demand side barriers to care, also through quantitative investigations, supply side barriers to care, which often included, the level of stock and supply available in each of the facilities at primary care levels, and then ensure that we engaged with all of the actors that were critical players in healthcare and civil society for the populations that we're looking to serve. But I think critically in the case of Brazil, South Africa, and India, and actually also the US, we developed public-private partnerships from the outset to ensure that we were helping to answer questions that governments had in their own support for underserved populations in these settings, and have continued to maintain those partnerships as sort of a critical part of policy and advocacy. So from the needs assessments, we went into a monitoring and implementation stage. And we will get into some of the lessons from that stage in the next few slides. And then again, we are looking to measure outcomes, improvement in A1C management, at blood pressure levels. We are looking at LDL cholesterol in some places. And then particularly in the case of the United States, a decrease in the utilization of emergency rooms and hospital care. But in addition to those sort of clinical outcomes, we care a lot about patient satisfaction, the experience of frontline health workers, and again, the supply of commodities and essential drug therapies. So next slide. I'll start with Brazil. So Brazil is a context that has, as you all probably know, universal health coverage through the SUS system. So it was an interesting place to do a partnership. We have strong support and collaboration with the ministry from the start, which we felt was very critical, as well as partnerships with local universities, federal universities that had sort of a direct line to policy making. And there were a number of things that we uncovered in the case of Brazil and in a context in which universal health coverage already exists. But I think one of the key things is that we could help play a support in organizing care and trying to make the primary healthcare system more efficient for both the providers and for the patients. So a lot of what you see on the sort of promising practices side were innovations that came out of a program designed to sort of ensure that we were able to better track patients with hypertension and diabetes, and that we were better able to improve the quality of that care. So one of the elements that we used in that case was a clinical support decision tool, which was a proprietary developed software for primary care providers that allowed them to make better decisions in the clinical management of diabetes and hypertension, and also allowed them to use health worker referrals to refer better up to secondary care as appropriate, and linked to telemedicine as needed. We have some high usability and satisfaction scores that came from those providers, so we've continued to try to expand that clinical decision support tool. Also, A1C point of care. This is something that Evan mentioned earlier in the call. This was a place where it really made a lot of sense to do point of care testing at primary care levels. And so the team there did a number of investigations to ensure reliability of the tool and to ensure that it actually would work within the context that they were operating. And in fact, I think saw a great improvement in management of care. And so it's allowed physicians to adjust therapy and increase the time to target for each of the patients that have been part of the pilot for that. We've seen improvements with that innovation. And also really importantly, in the context of Brazil, we've worked in to develop local patient associations. So this is part of the ensuring that we have strong self-care and peer support groups, and that those communities are actually able to continue to pressure health systems to get what they need. So one of the approaches that we used in supporting those local patient groups was storytelling training. And that has actually proved to be quite an effective tool for those local organizations. Next slide. So India, this is a place where we looked from the very beginning. Our needs assessment showed us that actually the number of people we had a high prevalence of hypertension and diabetes, but the proportion of people who knew it was quite low. Only about a third of patients had an awareness of their condition. And so this was a place where we knew that we needed to both improve awareness and detection, and then systems to refer and retain patients in care. So when you see the report, you'll notice that there is a much longer in-depth review of the electronic health card. This was one of the ways that we reached out to communities to assess their risk and to screen patients, and then to refer them into a system of care. It was developed actually at the request of the government in Himachal Pradesh, where we're focused. This wasn't initially something that we went in to do, but because of these partnerships and needs assessments, it was a key priority, and so we agreed to develop it together with the government of Udaipur and in Himachal Pradesh and Shimla. And so far, we've trained about 2,000 ASHAs in its use, and the government has actually been able to roll it out to about 400,000 people to track risk and also to refer patients and longitudinally track them in care. Another really important dimension of the India program has been in self-care and peer support. So we have about 324 patient support groups that are piloting something called the Community Life Competency Process, which is a process that comes out of HIV, but is really about creating patient groups that can sustain over time. And those groups are taking care of each other and supporting lifestyle adjustments and therapy adherence for diabetes and hypertension improvements. And it's really about the community owning the solution and owning their self-care. And we've seen really great results. Again, when we have evaluation numbers to show, I think this is an area we'd like to continue to highlight. Next slide. And so South Africa is the last country that we'll spotlight here in our example, but South Africa is a place where we knew that to be successful, we needed to integrate into a number of reforms that were happening within South Africa. They were transitioning to something called the Ideal Clinic in primary care that was looking to improve the efficiency and quality of primary services. It's obviously a country also that has a rich platform developed for HIV and TB and other infectious diseases. So we knew that, from the beginning, it needed to be an integrated approach. So I think we really took the lead from our local partners about where we felt they were best placed to begin that integration. And one of the key places for us, and it was, I think, sort of key in seeing improvements in the program, was an investment in the health workforce. So from community health workers who were mobilized in a number of places already for other conditions, but had low levels of awareness about diabetes and hypertension, we were able to train a number of them. We were in 2 different sites. In one of the sites, we had our own HealthRise community health workers, and trained also about 50% of them were our own and 50% were government, because there was a restriction on invasive, what the government considers invasive screening or management of these conditions. And so that included capillary pricks for diabetes, as well as blood pressure measurements. And so given that restriction, I think we were able to show that through our own community health workers, they were quite capable of screening and supporting patients at the level of the home through sort of ongoing chronic management. And so that was an important thing to help demonstrate now that South Africa is going through their own policy reforms about what community health workers can do in professionalizing that cadre of health worker has been an important input. But we've also realized that it's really critical that those community health workers and that the frontline system is well equipped. Katie mentioned at the top of the call the need for local guidelines and protocols that are well understood and supported at primary care level. And that was certainly the case in the locations we worked in everywhere. I'm calling it out here in South Africa, but the way that we sort of addressed that was by ensuring that we had strong nurse mentorship. There were clinical mentors within health facilities that can mentor other nurses in diabetes detection and management and hypertension as well. And also we're able to supervise the community health workers. And so this sort of mentorship and team-based approach that Evan alluded to was really critical for us to ensure that we had early detection and limited complications for patients, really improving quality of care. And lastly, recognizing again everywhere was critical for us to address social determinants of health. And so we attempted a few things in South Africa, including community gardens and village savings and loans programs, ways that patients could access healthy foods and perhaps some income to support their families and support care management. And I think some of our challenge with that is that it can be difficult to sustain. We've tried to develop partnerships with the agriculture sector, with education and others outside of the health sector, but that requires investment, and so I think yet to be seen if that's something that will really financially sustain. Although certainly that is the hope. So I'll close here on the left. I think it's the last slide. Sorry, we have two more. Just key emerging lessons. Important for us to improve the capacity of frontline health workers in follow-up care, linkages to care, and navigating social determinants of health and really adherence at a household level. So they were absolutely essential to the ongoing detection and management of hypertension and diabetes. And I think we continue to see that cadre of health workforce as really critical to long-term chronic management and improved outcomes. We also saw that patient empowerment and self-care could be aided by those community health workers, and that we had, especially when those health workers had tools and information systems to link them into longitudinal care. So just in the interest of time, I will just mention that we've had a number of challenges along the way, including high number of people screened and low conversion into diagnosis, which we use transportation and capacity building of community health workers, a number of other strategies to address. And then sort of these issues of low retention and community support activities. I think the more peers that we got engaged and the more we were able to integrate management of disease, including, getting community health workers to bring blood pressure testing and glucose monitoring to those community support groups, the better participation we had. And then also managing the increased demand once we had it at clinics, which required improvements in efficiency. And I would say all of this, it was critical for governments and our other local partners to be very engaged in owning solutions. And this is what we think will ultimately drive sustainability. So I'll stop there. Thanks.
Thanks to you, Jess. We've got one question that came in, which will actually be really well answered by the next presentation, and that's just on the integration of NCDs with infectious diseases like HIV, which will be covered in the next presentation, but also tuberculosis and maternal and newborn child health. So can I ask if there's anything that you want to add to that specifically from Medtronic's perspective before we move to the next presentation, or if it's better to open it up to more questions after that? What's your preference, Jess?
No, I think that's a great question. I will just say we had some challenges in IRB approval and getting access to health records of some of those patients, which constrained our ability to give evidence on it, but we think it's absolutely critical, and I'm looking forward to the next presentation.
Thank you. And just one more about what advice can you give about sustaining the good lessons in a place like South Africa, where its health system is in crisis?
Yeah, I mean, the only thing that I can say is that the local solutions really mattered, and those solutions were owned by local governments. So even municipal level governments and state level governments are where we focus with national level engagement, which we were fortunate to have the whole time in South Africa. But I think that the more that this is sort of seen as part of helping to support that, there are still resources at that level, and they can be optimized. So I think there's huge potential. It just needs to be locally owned.
Thank you, Jess. Okay, so if we move on now to Chiti Asiwa, who is with AMPATH based in Kenya. And for the question and answers, can I ask people, as a question occurs to you, please feel free to type it into the box as it occurs to you. There's no need to wait until the Q&A period, and that will make it much easier to coordinate everything. Thank you very much. Okay, Chita, over to you. There's quite a lot of background noise. I don't know if there's any way to address that. That's already better. Thank you. Chita, over to you.
Okay, thank you so much. Can you hear me?
We can hear you perfectly.
Okay, thank you. Next slide, please. I'll be talking a little bit about how we've been able to integrate some of the activities for cancer care using the platform that was initially developed for HIV programs that still continues to date. So AMPATH, for those who may not know, is a collaborative partnership between Moi University, Moi Teaching and Referral Hospital in Kenya, and a consortium of North American institutions led by Indiana University. Throughout the program, we've had initially built for HIV program. We've had more than 160,000 patients go through the program, and currently more than 120,000 still retained within the program. So there are so many lessons that are already in HIV that we picked up from when we started the cancer programs about 10 years ago. I'll use this as an example, but there are several other things I'll be mentioning along the way. The program title is AMPATH Breast and Cervical Cancer Control Program. This is a program that has been funded by Lilly Foundation Global Health Philanthropic Programs. And we're happy about this, and the dates are starting October last year. Next, please. So the goal of this program is basically to improve the access to screening and diagnostic services for breast and cervical cancer in Kenya, but mainly addressing the barriers for cancer care through a population health approach, and definitely working with those communities and ministries of health within those counties, and with a potential to scale this up next. And the activities that we mainly involved ourselves with within this program include clinical care, where we are doing screening, early diagnostic treatments, timely referral, palliative care, and survivorship. I'll say something a little bit about this, that we already had the HIV program. And the good news is that they already had more than 100 sites in Western Kenya, where the HIV program had already collaborated with the local communities and even set up some programs in collaboration with the Ministry of Health and the county hospitals in those sites. So it was very easy for us to overlay on that in terms of getting to increase our reach to all these sites. We started initially, we have what we are calling a hub and a spoke model. And the hub and spoke model is basically that the cancer center within Moi Teaching and Referral Hospital in Eldoret is the hub. And then all these other sites are spokes. There are some spokes that are closer and they have more things. So we'd go to a center and find out what are the things that this center has. So initially we'd say, do we have a pathologist? Do we have a surgeon? Do we have a radiologist? Are there some things that can be done? And working together with that center, we would figure out what are the things that we would need to improve in order for them to start even the basic care, whether it's screening or early diagnostics. And so there are some centers within which we've developed working together with these communities that are able to actually be able to do biopsies. We give them quality control and assurance to ensure that the diagnosis is properly done. Immunohistochemistry are done in 2 of the several centers that we have. And so there are several things that are different depending on the center. And then within these centers, we've realized that if you are giving clinical care and you just say we'll do breast alone and cervix alone, then it does not really help a lot, because we believe in a population-based approach, in the sense that if you potentially cure somebody from breast cancer, but they die of TB or die of hypertension or diabetes, you really haven't really done much to the population. And so how we approach this is that working with our community health workers who are delivering the HIV care and talking about TB, we evaluate them with additional information about where the breast and cervical screenings are being done, and a little bit pamphlet about what breast and cervical cancer screening is all about, and where if somebody has even a swelling, like right now we have other people we call spotters who are able to spot somebody with a swelling or a mass that they can refer to the hospital for prompt care. Then the second thing that we do in this activity is education and training. And within education and training, initially earlier on, we discovered that if you go to a center and say, or a county hospital and say, I would like to have a few nurses to train for breast and cervical cancer, the nurses that are given to you for the training, if there are 2 or 3, then the entire hospital expects those nurses to be the only ones doing this. And when they have additional responsibilities or they are on leave or vacation or something, then that service of screening is not there. So what we decided to do, we have 2 levels of training. We train everybody in the center about the importance of screening and what we actually do. And then we get quite a number of people in all the various departments, whether it's maternal child health, as well as the cervical cancer screening clinics. In this way, then they all feel responsible for screening and treatment. And the other thing is that all these people are actually employed by the county hospital, so we do not really have to invest in employing new employees in those centers. We discovered leadership and administration is actually part of the activities we do in breast and cervical cancer control program, because we noted that quite a number of leaders, really we needed to see how can we integrate all the things we do. And here I mean that if, for instance, we have within the county hospital, we have an NCD team. So it made no sense for us to start creating a different team for cancer care when they already have an NCD, a non-communicable disease team that was already doing some work. So we would actually ask them, can we sit through your meetings? Can we figure out who is your point person that you'd like to lead on cancer care? And that actually increases ownership, as we've noticed, and also helps with allocation of funds by those counties when they are prioritizing their health needs. In our program, and this is largely due to the HIV program, we already have a very well-known electronic medical record system that is called AMPATH Open MRS. And within this medical record system, the HIV data for all the patients that have been through our system is actually captured and recorded from the point of care. And therefore, you can actually be able to access this information and not lose a lot of data and enter it correctly. And so from that team, we actually just overlaid on it the breast and cervical cancer screening electronic forms, as well as developing of initial and return encounter forms for major cancers, including breast and cervix, whereby when we go for screening, we actually just carry our handheld devices. We don't carry any paperwork. And during screening, there are questions that you just go through and enter into this electronic database that automatically stores, and you can be able to review this information anytime and follow up with these patients. Then with this program, we're also assisting in the development of Biobank and a Center of Excellence in Pathology. Next, please. Then, in addition to these activities, some of the things that have made us achieve quite a bit is, and I won't really emphasize on this because all the presenters from the initial presenters mentioned this, collaborating with the communities is key, and ensuring that you have a good entry point, which ensures that we are both speaking to the Ministry of Health level in the government of Kenya, but most importantly, the local county ministries of health. Integrating the services, not only breast and cervical cancer, but also diabetes, hypertension screening as well. And we've actually, as of January this year, we've been able to include cough monitors in terms of integration of lung cancer screening and prompt referrals. And these cough monitors are usually the first line of defense for TB in the rural communities and the rural hospitals. So we've been able to to capture this and train them more on how they can be able to identify patients who perhaps need further investigations. We individualize the care. We work with behavioral scientists that look at the culture, the language literacy levels, so that all the material that we develop, and this is also shared with other NCDs, and this helps us to reduce the cost of the amounts that we are doing on each of these. Next, please. Then this information, one of the things we notice as a positive feedback towards the groups really being invested in being part of this program was being able to communicate what we find, and communicating this both to the lower levels of the healthcare system, but also to the upper levels. So at the Ministry of Health, we are communicating the data that we collect, but also we return it back to the county hospitals and the communities so that we can work on a strategy of improving the outcomes. And then we hope that this is scalable and sustainability. Next. These other slides, I won't emphasize much on them because it's actually just about some data from January this year. We screened about 11,000 women, 115. Next, we've had abnormal findings, as you can see. Most of these women on the next slide are mainly disease diagnosed at stage 4 and stage 3, as you can see, which we are hoping through this program as we get, in fact, I would say this, that 8 years ago, when we wrote a paper on the disease stage at presentation of breast cancer patients, we own 100% of them are stage 3 and 4. So we can already be able to see that within a short period, we are seeing a few stage 1s and a few stage 2s. We hope that as we do this over the next 5 years, we shall see changes in this graph showing that the community program is actually being effective. Next. For the cervical cancer, is the same. We've done more than 24,000 screenings for women for cervix, and this is just some data from what we are seeing. Most of the screenings that we are doing are actually clinic screenings, and we prefer clinic screenings because this means you establish a routine clinic in a site. You train the people in that clinic that will be able to respond to these patients when they come. You go and help them screen. You provide mentorship. So we have some clinics, we have a consultant going every week to those clinics to assist in mentorship of the healthcare workers. Some clinics are already well established and the consultants are pretty good in what they are doing. So we just have telemedicine and virtual tumor boards with them to discuss patients. But we've also included mass screening because mass screening means that it gives us an opportunity to actually directly respond to the community's needs, but also gauge what else is affecting the ability to come to the clinics and to come earlier to present for their conditions. The next 3 slides, you can just run over them, is actually just showing some information about cervical cancer. This slide just shows the number of screened versus the ones who had abnormals. The next one is just showing the percentages of this, and the next one shows about treatment of these patients. What you can see in this next slide, which shows about all cervical cancer patients seen in our program since 2007, you can actually see that from 2007 to now, sorry, I think we went ahead, but it's okay. You can see from 2007 to 2018, we've actually been seeing increasing number of cervical cancer patients, and 2018 was the year that we diagnosed most patients, 180 cervical cancer, and because of these robust screening programs that we have in the communities and uptake of these communities to our programs by integrating them. And of course, I have to say that the Ampath Breast and Cervical Cancer Program funded by Lilly Foundation also was part of this. This is a very interesting thing. So when you screen for cervical cancer, you find other cancers. You find ovarian, endometrial, vulva, and all that. And although this is also good for us to be able to find these cancers early, then when you develop a program, your question is, what do you do with these other cancers that you are finding if you don't have funding to assist? Next. So I'll mention a little bit about challenges and solutions within the same breath. And one of them I've already said, that when you are screening for these non-communicable diseases and cancers in particular, you end up diagnosing other things that you are probably not funded to be able to do. However, one of the things that we've discovered is that because of our many programs within the HIV and cancer program, and the integration really helps a lot. Because when I get a hypertensive patient, instead of wondering on what I should do exactly, I have a colleague of mine who is seated within the next room that can actually take over and start from there. And when they find a patient that perhaps has a breast mass, then I can see them. So making them integrated really helps in that. Then most counties had not been prioritizing funding for non-communicable diseases, but we've assisted in solving this in 3 of the counties by our members really being part of the county NCD meetings. So which means whenever they are having their monthly non-communicable disease meetings and they have the entire county team, our teams are there to give first some feedback on what we've been finding on the ground, working together with their teams, but most importantly to assist in resource allocation, because a few counties would have some money to allocate to some cancer screening or either NCD, but prioritizing, since they didn't have the expertise, was an issue, and we've noticed that is helping. Slow procurement processes, that was an internal that we are working on. The uptake of electronic data capture among clinicians is always low unless you start giving them reports and showing them the data that you put, it's actually making your work much easier. when we started printing reports and putting them in the files of the charts of patients for these clinicians, all of them are excited. And now we have almost 100% uptake in most of the centers. In fact, whenever we go for cervical and breast cancer screening, none of the clinicians would like to use paperwork. They all prefer to use palm tops. And then what do you do with these other chronic conditions? So the solutions, one of the things is when we are training for cancer, we don't train only one group. Training across the groups is important. And so we have a basic training curriculum for community health workers. And this one includes diabetes, hypertension, but we also have a little bit information about cancer and TB. Sometimes people may think you are overloading them, but we just say the take-home messages are the following: whether to refer the patients to, showing them that we already have an organized referral pattern, and there is a number to call in case you see something you don't understand, and we have telemedicine or video conferencing that we can do with them to assist in care. The other thing we emphasize multidisciplinary care for these patients, and we have deliberations in meetings where we have the entire team of population health, which will have a behavioral scientist, a primary healthcare worker, myself, cardiovascular doctor, and all of us sit together to learn not only from the community but also to share some of our experiences, which we've noted that experiences in terms of non-communicable diseases are similar in a way. Some may be a little complex, but it's still similarity. And then importance of mentorship, without really giving that mentorship the quality of care that we give, we notice that may not be optimal. And so there are some centers that we send our teams there physically. Several doctors go to the sites. We've introduced electronic medical records in cancer care. The other important thing is the government of Kenya. We've been working with both the national government as well as the county governments, and we've included non-communicable diseases screening in addition to breast and cervical cancer screening as part of the National Hospital Insurance Fund and whatever the insurance fund covers. Currently, it's covering for a few chemotherapeutic agents and covering a few things for patient care, but we included also the screening component. And this was stronger because of having an NCD group approach them at once was important. We talk about sustainability. Treating a patient is much more than just giving them care in the clinic. And so we have groups that help in helping these women and the community to actually develop community programs, social enterprises, like one we call the Gishe groups, where they do some microfinancing activities. They raise funds, they try to help each other. If somebody wants to start some farming, they are able to do that, because we realize if they do that and then we introduce them to insurance and they see the importance of that, then they can actually be in charge of their own care instead of waiting for grants. And then lastly, the referrals that we do are both the referrals that make sure that you refer patients upwards and downwards. So every time a patient is referred to us from a cough monitor, we have a team that actually ensures that the cough monitor who referred the patient knows what exactly was the diagnosis and what was the plan. And this actually helps them to refer them upstream, because they know that we consider what they do very, very important in our care. And then things like monitoring and evaluation we do together. Now, within diagnostics, one last thing before I finish is that if you look at the HIV diagnostics, for instance, flow cytometry, we were able to use the same platform, but now we are doing flow cytometry for lymphomas and leukemias. And we've trained a team that is able to do that, but we actually based this within even the same lab that the HIV clinic is. Some of the things like, for instance, doing VIA or VLI with this cervical cancer patient. I remember in 2011, I would be the one or one of the consultants seeing all the women who need screening. But now we've been able to do some task sharing, and we've taught nurses on how to do this. We've taught them how to take pictures so that we can ensure the quality of what they did. We've shown them what to look out for and what needs biopsy. And then when we are in clinic, we are able now to see much more complicated cases. So we run these clinics at the same time, but the nursing staff and the middle level trainees, whom we call clinical officers, will be seeing the routine screen patients, but then us guys will be able to offer the back end of support. So I think I'll stop there and wait for questions so that we can elaborate more. Thank you.
Thank you, Chite. So you really briefly mentioned monitoring, and so there's a question that's come in from Janine again, asking if the AMPATH electronic database is part of the national or the ministry MRIS, which I'm assuming is a monitoring database. If so, can you share anything on how you manage this and what you can learn from having a single process, having a unified monitoring and evaluation system at country level?
Oh, thank you so much. So AMPA's electronic medical record system has a lot more than what the Ministry of Health usually requires for monitoring. So we ensure that we work together with the Ministry of Health to identify what are the specific things the ministry wants to be monitoring on a routine basis. Within the cancer realm, they would like us to be monitoring the information that we collect in cancer registry, the CanReg 5. And therefore, we decided that within our system that we develop for care or even for screening, it has all those components that need to be monitored. So we can be able to print out or even send the information directly electronically to the ministry. However, what is within AMPA's electronic medical records is a lot more because we collect so much data, hoping that we could develop some more hypotheses and other research in future.
Thank you very much, Chite. I'm going to move on now to just a few final closing words from me to give a bit more of the political context from where we're heading next in this area, and then we'll conclude the webinar. Thank you. And Janine has just said thank you for such a comprehensive answer. So in terms of where we're heading next to accelerate integrated care for NCDs in the context of universal health coverage, just to look very briefly at the case for universal health coverage, still half of the world's population does not have full coverage of essential health services. That's not even all health services, only essential health services. And about 100 million people are being pushed into extreme poverty because they have to pay for healthcare. And this clearly needs to be addressed, not just for the sake of health, but for the wider context of sustainable development. And over 8 million people spend at least 10% of their household budgets to pay for care. And we know from the 2030 Agenda for Sustainable Development that one of the key targets under Goal 3 is to achieve UHC. Next slide, please. And when we define UHC, there are 3 objectives that are encompassed within it. So equity and access, but also to do with the quality of health services that are provided and to make sure that they are good enough, sufficient to improve the health of those that are receiving those services. There's no point services being available if they aren't of sufficient quality. And final, financial risk protection to ensure that the cost of using care does not put people at risk of financial hardship. And you can see the diagram at the bottom. A lot of you are probably already familiar with it, but it outlines those dimensions in terms of population, who is covered, services, which services are covered, and whether or not direct costs, which proportion of those costs are covered, and the measures that need to be taken to ensure full coverage of all of those 3 dimensions, also included in the diagram. Next slide, please. Fortunately, Tedros is championing the whole issue of UHC, which can be denied by no one, his catchphrase being all roads lead to universal health coverage. And we've seen this reflected not just within WHO, but also more broadly. To move to the next slide, UHC is one of the pillars of the WHO General Programme of Work and the 13th General Programme of Work, which runs from 2019 to 2013. And this is where the triple billion targets that we hear mentioned so often come from. So one of these billions is 1 billion more people benefiting from universal health coverage, and then the two other billions are 1 billion more people enjoying better health and well-being, and 1 billion more people better protected from health emergencies. But you can see that these priorities are all very interlinked in any case. I'm actually going to skip over the next slide and move straight to the one on 1 billion more people benefiting from UHC. And this just outlines WHO's priorities to enable universal access to strong and resilient people-centered healthcare systems. And just shows, how we need to maintain a comprehensive approach to the issue of UHC and ensure that we're considering all angles as much as possible, and not to be too focused on solving an issue in one area while ignoring all of the others. It's got to be seen within the more holistic context. To move to the next slide. So the on the 40th anniversary of the Alma Ata Declaration, just more than last month, just over back in October. There was a global conference in Astana in Kazakhstan to essentially update the Alma-Ata Declaration, and the updated version is the Astana Declaration, which many people will be familiar with. But what it's really important to say is that it really reflects the change in the global health burden that has been observed over the last 40 years, and there are mentions not just of non-communicable diseases, but especially of the importance of integrated care. If you haven't read that document, I highly commend it to you, but I'm sure many people will have done. To look at what's coming up in 2019, we've of course got the World Health Assembly. Last year, the theme of the World Health Assembly side events and much of the assembly itself was on health for all, and it's quite likely that this might be the case again this year, just given that the high-level meeting on UHC is around the corner. Just to highlight that the high-level meeting on UHC was initially scheduled to be on the 26th of September, but we're now hearing that this might be moved to slightly earlier in the week, but everything is TBC. But even though the modalities resolution has been decided, there is some discussion over whether the date will be moved. And we're already on the next slide. Thank you very much. And on that note, I don't think there are any final questions, but thank you hugely to all of our panelists for sharing such fascinating and invaluable information. Oh, there is a question. So I think that's actually a comment in the question box rather than an actual question. So Janine, it will be great to be in touch more after the webinar. Thank you very much. Yeah, a huge thank you to all of our panelists for sharing what they've shared, and of course to Lily for its ongoing collaboration with the NCD Alliance. And I wish everybody a wonderful rest of your day. Thank you very much indeed.
Thanks. Thank you.
Thank you.